Pamela, Youde, Nethersole Eastern Hospital to deliver his talk. Thank you. I would request Dr. Jeffrey Chau to kindly unmute himself and start his speech. Thank you. If Dr. Jeffrey is not available, I think we can go with the next speaker. Okay, I would request. Okay, I would request Dr. Osnat Wende to start his session.
Okay, that's me. Can I share my own PowerPoint, because I've made a few changes since I sent it in.
Okay. Host kindly make Dr. Osnat co-host, please. Thank you.
B, come and show me how to.
What do you want to do?
Okay.
What do you want to do?
Yeah, that's it. Is it there?
Yeah. 1 second. 1 second. 1 second. Okay. Ask if they can. Did you share your screen or not?
I didn't. They want me to share.
No.
1 second.
Where is it? That's it?
Yeah.
That's it. On?
Yeah, okay.
Okay. Ask if I can see it.
Can everybody see that screen?
Yes, yes, we can see you.
Okay, I'm just going to silence my phone.
I'll do it.
Okay, so thank you. First of all, thank you very much for inviting me. It's an honor to speak here. I'm Dr. Wendy. I'm a senior pain physician. I work in Hadassah University Teaching Hospital in Jerusalem, by the way, which is behind me, which is in the background. That's Hadassah in the middle of the mountains. I lead the treatment of musculoskeletal pain in the pain unit. And so I'm going to speak to you today about ambulatory treatment of partial rotator cuff tears with an emphasis on regenerative medicine. So we all know that the shoulder is the most mobile joint in the body, but this comes at the expense of stability. And also we get much more wear and tear. The shoulder joint is much more vulnerable to wear and tear of the various tendons and stretching of ligaments and so on and so forth. 1 second, Dubby. Dubby. I've got to share it.
What do you want to do?
Got to go into 1 second. Sorry, it's not.
Yeah. Okay.
What did I? Okay. Okay. So I have no disclosures. So the lecture outline, I'm going to present commonly ignored predisposing shoulder pathologies. And if we do address these shoulder pathologies, then we are more likely to get long-term results. I really haven't got time to talk about the literature, which I plan to in the 20-minute lecture. I'm going to talk about the regenerative principles to apply if you really want to maximize your results. I'm going to present some examples where to inject. And then I'm going to give you some simple exercises to prescribe also to maximize your therapeutic results. So, okay, so our aims in regenerative medicine, first of all, we want to strengthen this regenerative. We want to strengthen the structures around us. We want to strengthen the tendons, possibly even healing the small tears. I don't aim to repair massive tears, but we can definitely heal small tears. And even if in patients who have massive tears or large tears, we can still strengthen the supportive ligaments, supposedly to try and prevent this superior gliding of the humerus, and it can lead to rotator cuff arthropathy. So basically, we want to strengthen the structures that are viable and to prevent also further damage. So the tendons that we treat are the supraspinalis, the infraspinalis, and the subscapularis, not so much the teres minor. And the ligaments we can treat are the glenohumeral ligaments, which make up most of the capsule, the acromioclavicular ligaments, and the coracohumeral ligaments, which I will talk about later. So there are several sorts of regenerative treatments. The cheapest one is dextrose prolotherapy, which is basically using dextrose of various concentrations. I use 20% in most of my treatments. You can use platelet-rich plasma or platelet-rich fibrinogen, which I use also. Some people use bone marrow, aspirate or concentrate. You can use fat injection, and also ozone, amniotic fluid, exosomes. I have absolutely no experience with the latter three, but they are also regenerative treatments. So I'm just going to show a few pictures of people with various shoulder dysfunctional pathologies. And I just want you to take a look at those and try and guess what pathology is going on here, what there is here. So here, looking at this boy here, you can see that both of his shoulders are higher than normal. They go, and the scapulae span from T1 to T6 instead of from T2 to T7. And both the scapula are adducted. Here you see a lady who's complaining of right shoulder pain. You can see that her right shoulder is lower than her left. Same with the right scapula. And both scapulae are downwardly rotated. I'm going to see myself so I can show my. Yeah, so both scapulae are downwardly rotated like this, which means that the scapula has to sort of, the rotator cuff has to work harder to achieve that 90-degree abduction. And I'm going to go into a little bit more detail. This is a picture of a guy who leads a very sedentary life. He spends most of his day in front of the computer, and you can see that his scapulae or shoulders are very much forward, and his shoulders are sort of medially rotated. So this also compromises shoulder function, which I'll explain soon. And this is a picture of a lady with left shoulder pain. You can see that both scapulae are very much anteriorly tilted like this, which will lead to compromise of the subacromial space, which I'll demonstrate soon. So the first phenomena of these, first of all, we must recognize that the scapula contributes to 1/3 of shoulder abduction. So if the scapula is not abducting properly, and it should be reach the mid-thoracic line here when we shoulder abduct, if the scapula doesn't abduct properly, then we have a lot more burden falling on the rotator cuff to do that movement. And we must recognize that there are 4 joints in the shoulder girdle. It's not just the glenohumeral joint. And if you have a dysfunctional acromioclavicular or even a sternoclavicular joint, and definitely the scapulothoracic joint, even though it's not a real synovial joint, if those aren't functioning properly, then the shoulder, the glenohumeral and the rotator cuff is going to suffer in one way or another. So I want everybody to stand up. This is a little exercise. Everybody stand up. And I want everybody to stand with your really slouched, with your shoulders sort of rounded and your shoulders medially rotated. Everybody do that. Get up. And your palms should be facing the back. I want to just demonstrate something it's much more extreme than what we see, but just to demonstrate a phenomenon. And when you're standing like that with your shoulders medially rotated, I want you to try and abduct your shoulders as much as you can. See where you get up to. And you'll see that you get to about 90 degrees, 100 degrees. Now I want you to stand upright, chin straight, arms by your sides. Your palms should be touching your thighs. And now I want you to abduct your shoulders all the way. And you'll see that automatically halfway through abducting, do it again, you will see that at about 90 degrees, your shoulders laterally rotate. And this is a present that God gave to us so that our supraspinatus tendons can escape the acromion as we abduct. And this prevents a lot of wear and tear. So if a patient has limited lateral rotation, then there's going to be more wear and tear of the supraspinatus tendon with the impingement from the acromion. So therefore, it's very important to assess shoulder alignment. And if someone is not laterally rotating enough, we should give them exercises to strengthen their infraspinatus muscles. The third condition is the anterior tilting. So here I have a model of a shoulder. Okay, you can see this, one second, this is the anterior. Here is the coracoid coming here. And as you can see here in the diagram, you can see that the pectoralis minor tendon attaches to the coracoid process. And when it's short, it's going to pull that whole scapula down and forwards, which means that the coracoid is going to come down, but also the acromion is going to come down and forwards, which means that the whole subacromial space here is going to be diminished, which means that you're going to get more wear and tear of the supraspinatus of the rotator cuff. So if we see someone with anterior tilted shoulders and they haven't got a permanent deformity of a thoracic kyphosis, we can try stretching their pectoralis muscles, because that is what's doing it. That's the culprit of what's going on. And that takes a lot of perseverance to do that, but it's worth it. So the regenerative principles. First of all, we must recognize that multiple pathologies coexist, especially in chronic cases. Because when you have a problem on a particular structure, you're going to have the other structures around there, the neighboring structures, recruited to try and withstand that stress, those stresses. And we must understand that a stress doesn't fall on one little tendon, it falls on a region. And so if you're going to inject one little tendon, we can't expect to get long-term results. We have to address that whole structure, the whole region, if we want to get a good long-term results, and especially to prevent further damage. So the preventative principles we have to, the more thorough your approach will be to treatment of the shoulder girdle, the better and longer lasting your results will be. Also, not just addressing the tendons, we want to address the ligaments of the shoulder capsule, especially in the older people when they have massive tears and you want to prevent the superior gliding. I haven't done a study to show how this prevents it, but I have noticed that patients, even with massive tears, do improve in function if you treat this. So the ligaments of the caps of the shoulder actually provide a lot of stability. And so here is the coracohumeral ligament, which I'll talk about. Here is the superior glenohumeral ligament behind there. And here is the middle and the inferior glenohumeral ligaments. And of these, the most important are the inferior and the superior, which I'm going to talk about soon. And here also the coracoclavicular and coracoacromial ligaments, and the acromioclavicular ligaments as well. So just a quick look at the shoulder under ultrasound. So we want to expose the supraspinatus, which is normally under the acromion. So in order to see that under ultrasound, we have to immediately rotate that shoulder and put it behind on the back pocket. So you can see that the probe is aligned with the humerus here. And this is a longitudinal view of the supraspinatus tendon. You can see the footprint on the greater tuberosity. And here is the humeral head. And here is a thin line of cartilage over here over the top. And you can see that the fibers are very nicely aligned along the supraspinatus, area. All these fibers are very nicely aligned. This is not a tear, okay? It means that it's at anisotropy. In other words, because the fibers are coming in from a different direction, they're not perpendicular to the probe, and therefore they're going to look black and hypoechoic or anechoic. But if you just toggle the probe around, then you'll see that. If you want to rotate that probe around 90 degrees and look at that in short axis, in other words, the fibers normally are coming sort of down across from under the acromion and inserting this way. But if you want to look cross section in that way, then you turn the probe 90 degrees. And you'll see here is the humeral head, here's the cartilage, and here is a nice thick supraspinatus tendon. It's all even, uniformly even in height and width, and that's a beautiful tendon. So that's a short axis view. So the type of tears, okay, so here's a normal supraspinatus tendon. This is the bursal side. Here is the articular side. Here is the imprint on the greater tuberosity, okay, that's normal. The articular sided tear, a partial articular sided tear, is on the articular side, as the name implies. So you have a tear that doesn't go the full thickness. If you tear, a full thickness tear doesn't mean it goes the whole width across the joint. It means that it goes the whole depth of the tendon. So if a full thickness tear would go all the way from the bursal side to the articular side. And here you see a partial tear, a demonstration of a partial tear that goes from the cartilaginous side, some partially halfway up or some of the way up through the thickness. And these are the sort of tears you get in the elderly, which, by the way, are more amenable to treatment. The Bursal-sided tears are what you get more commonly with athletes, and these are more difficult to repair. They have a poorer prognosis. So the tear is on the bursal side, as indicated, and because there's no tissue there, you sort of get a gap in the tissue there, and the bursa falls, and you sort of see that sort of, I mean, I've exaggerated it here for demonstration, but that's sort of what you see. You sort of see a sort of a dip. And these are more difficult to repair. So this is the subscapularis coming up. Subscapularis comes across from in front of the scapula across to insert into the lesser tuberosity. So this is laterally towards the lesser tuberosity. You can see the subscapularis here. This is a long axis. And here is the side of the coracoid. You can see that's normal. And here is, I haven't got time to show all the views of all the tendons, but here is the infraspinatus, also long axis. Sorry, there's a spelling mistake here. It should be L-O-N-G. And you can see that here's the infraspinatus tendon. It looks really nice, beautiful parallel fibers going across. Here is the humeral head. Whoops. Humeral head and the cartilage across there. It's got a nice level of cartilage. If you go a little bit more laterally this way, you will see the tendon sort of thinning out and sort of inserting into the lateral facet of the greater tuberosity. So I'm just presenting a few pictures of patients who I treated with prolotherapy in the public clinic in Hadassah. This is a picture of an ultrasound picture of a guy of his supraspinatus tendon. He was injured in a terrorist attack. His bullet went sort of from the side through his supraspinatus, coming from the front actually, through the supraspinatus, then back at the infraspinatus, coming out of the infraspinatus, and then tracking up the back towards his neck. You can see he's got a fracture here in the greater tuberosity. And you can see this sort of partial thickness tear sort of going along here. It doesn't quite get the full thickness. Okay, if you take it in short axis with the probe this way, so you see the fibers coming across, you see that the width hasn't dipped, it hasn't dropped. Okay, you've still got fibers more or less the complete here, and you see this break here, so you can't see underneath the calcium. So it's okay, and so you can see the tendon, the tear is partial. But this is after 2 treatments on the right-hand side. You can see that the fracture is healing, which it probably would have been without the treatment also. But you can see that these gaps are sort of filling up with collagen tissue. It's not, you don't expect to see a full, complete repair after 2 months, or even less. It was about 6 weeks. But you can see it's starting to fill up. And here also in the short axis, you can see that the fracture is healing, and this is sort of filling up with collagen tissue. This is of a lady, of 84-year-old lady. You can see her subacromial bursa is dramatically inflamed. Her supraspinatus tendon is basically sort of mostly torn. And after 2 or 3 treatments, I can't remember, but you can see that first of all, the inflammation of the subacromial space has subsided considerably, even though I didn't actually inject the subacromial bursa at all. I just injected the tendon. And you can see also the gaps are starting to fill up with collagen tissue. And here's a guy with the subscapularis tear. He had a 9mm tear in the subscapularis before treatment, and after treatment, that is filling up with collagen tissue. And that's all with just simple sugar injections. A lady with a 6mm tear. These pictures aren't so great, but this is done by an ultrasonographer. He saw that this is all the other pictures were my pictures. Okay, this is done by an ultrasonographer. He saw this 6mm tear in the infraspinatus, and here is not a fantastic picture. It looks pretty hypoechoic, but this area here where the tear was is, as he defined it, was completely healed. So the importance of the rotator cuff interval, okay, this is really important because this has a critical role in stabilizing the whole rotator cuff. So on the right hand side, you see the lesser tuberosity. This is all in cross section, okay? The lesser tuberosity here, the greater tuberosity here, the subscapularis inserting into here, the supraspinalis coming sort of towards here, and over the top of this is the bicipital groove. Okay, so that's the rotator cuff interval is basically from the greater to the lesser tuberosities. It basically includes the bicipital groove and everything in between. And across the top, you could see the coracohumeral ligament, which plays a very, very pivotal role, if I want to say it. So the coracohumeral has a the medial side of the coracohumeral ligament and the lateral side of the coracohumeral ligament, and it's sort of compressing down on the whole thing, providing a stabilizing force. And here is the supraglenohumeral ligament, which sort of comes across and inserts next to the long head of biceps tendon. So if you have a tear in the supraglenohumeral ligament, then it's going to provide less stability, and one's much more vulnerable to then progress to a partial tear of the supraspinatus or the subscapularis, and that can spread and degenerate more and more. And then you get both. So when I treat someone with a partial tear, I invariably treat this whole structure. So I'm coming, this is the lateral side, this is medial. You can see the greater tuberosity here, the bicipital groove here. Here's the long head of biceps tendon. Here is the supraglenohumeral ligament. And here is the subscapularis tendon. So here is a picture down below. I've got a needle coming, you can see the needle coming out down here. And with one jab, I'm injecting about 4 or 5 points. So I come in from the lateral, I'm injecting some of the fibers coming medial as far as it does from the supraspinatus, and inject the lateral coracohumeral ligament fibers. I'll go into the bicipital groove and inject the supraglenohumeral ligament. I'll pull that out, the needle out a bit, and then I'll inject here into the lesser tuberosity and onto the medial coracohumeral fibers. And then I'll pull out and inject the, and then I'll inject the subscapularis insertion. So with one prick, one jab, I'm doing 5 points. And each point I'm injecting just about 0.4, 0.5 cc's, absolute maximum, no more. So once we've also done our treatments, we want to maximize our therapeutic results, and we're treating the whole functional unit. And we talk about people, let's say, who don't have enough scapular abduction. So we want to release those muscles. And we can use dry needling. You can use stretches, but you can use dry needling to release those muscles very effectively. Here, when I'm needling the attachment of the rhomboids to the scapula, this is just needling the, you can't really see that, but that's just a I'm needling the trapezius muscle. And lastly, last but not least, is some exercises. So this is an exercise strengthening the infraspinalis muscle for people with medially rotated shoulders. To do that, you sort of abduct your shoulder, your arm so it's 90 degrees abducted, and the elbow is flexed 90 degrees. So you're standing with like this, sort of, you can't see me properly, but standing like this, your arms out like that. And I just tell my patients, even if to do it without a weight, or to take a kilo of sugar or flour or something, and to just sort of flop their arms backwards and forwards. I often ask my patients when they see me, are you flying? You know, they know what I mean. Are you doing their infraspinalis exercises? Just like that. It's very important. And the last exercise is of the pectoralis minor, to stretch it. And you can see lots of exercises on YouTube. You can go in and see how to do that. Make sure that it's not pec major, because that's a different muscle, although it may also be of benefit to these people, but pec minor is the exercise to do. And that has to be done religiously to have an effect on that. So if you want to get good results treating partial tears or any shoulder problem or any musculoskeletal problem, your treatment has to really follow a very methodical assessment. And you should address the contributing postural factors. You have to consider that multiple pathologies coexist, especially in chronic cases. And your treatment should address the whole functional unit if you want to get good results. So thank you very much for this honor. It was a pleasure to be part of this, and all the best. If you have any questions, I don't know if there's time for questions, but thank you very much. And thank you very much to Laura. I know I actually want to see Laura meet after all our emails. So thank you.
Thank you very much, Dr. Osnat Mende. And I would like to call upon Dr. Chau Xray, Pamela, Youde, Nethersole Eastern Hospital, to deliver his talk right now. Thank you so much. Can you please make Dr. Xray the co-host so that he can share his screen? Thank you.
I cannot share my screen.
I request Jessica to please make Xray host so that he'll be able to share his screen. Dr. Xray, you are the host now. You can share your screen, right? Thank you.
Okay. It's okay now? Can you see the screen?
We can see your screen, yes.
Okay, thank you very much. Okay, ladies and gentlemen, welcome to this lecture about our case report on the treatment of chronic diabetic foot ulcer with hyperbaric oxygen therapy. I'm Dr. Jeffrey Chau, an emergency physician and also an expert of hyperbaric medicine from Hong Kong. And this is my profile. I have my hyperbaric training since 2013, and I learned it from all over the world, including the States, Australia, and many places in Asia. And I also learned directly from House from Germany about the latest technologies in hyperbaric. And I would like to start my presentation with a case. This is a 62-year-old male with a past medical history of diabetes for 20 years. He suffered from a chronic non-healing wound on his right lateral foot for 1.5 years, as shown in the photo. He was admitted to the Orthopedics ward for wound infection and cellulitis, and he was treated with augmentin wound dressing and was discharged. However, he was admitted again a few days later for the right foot gangrene. An X-ray of the right foot was performed and showed osteomyelitic changes over the left fifth metatarsal and the base of the proximal phalanx. And this is the X-ray of the patient, and you can see the osteomyelitic change over the left fifth metatarsal and the base of the proximal phalanx. An emergency operation was performed for excision debridement of gangrenous wound, and then a CT angiogram was performed and showed there was stenosis over anterior tibial artery of both legs. Angioplasty was attempted, but the recanalization was failed. Orthopedic surgeons considered for rate amputation, but the patient refused. He was then referred to our Hyperbaric Oxygen Therapy Center for assessment and treatment. We assess the patient around 10 days after the referral, and the patient is fit for hyperbaric oxygen therapy and transcutaneous oximetry monitoring, which is called TCOM, later on, was performed. TCOM measured the oxygen partial pressure over the skin, and you can see that this is the electrodes was put around the wound to test if there are enough oxygen supplying the wound to heal. There are 6 sensors in this patient, but however, the second sensor is failed, so I have not put the result here. You can see that sensor 1, 3, and 6 were placed around the wound. This here is around the wound, 1, 3, and 6. While the sensor 4 and 5 were placed in more proximal region. This too is the sensor 4 and 5. To test the level where the leg become hypoxic. If the values are below 40 millimeter mercury, it means the oxygen level are suboptimal to support wound healing. If the result is below 20 millimeter mercury, it means that that part of the skin is in critical hypoxic condition. Besides this test, we will also have an oxygen challenge test done together with this TCOM. You can see that after a breath in oxygen in this area, you can see the arrow. Initial, the values is very low, and after the breath of oxygen of 100%, the sensor readings shoot up immediately. If the reading is higher than 100 millimeter mercury, that means hyperbaric oxygen may be useful to this patient. But if the reading is still lower than 100 millimeter mercury after breathing 100% oxygen, that means that there are significant ischemia is shown and further vascular workup may be needed. We have scheduled the patient to start hyperbaric treatment around a week later, and a total of 40 sections were performed according to the progress of the wound healing and also according to the further TCOM results, which I will show later. Okay, these are the further TCOM results, and you can see that the values improve from below 20 millimeter mercury in day 1 to above 30 millimeter mercury in day 49. When the values are above 40, it indicates that the wound was normally oxygenated and it can properly heal itself without further hyperbaric therapy. And the following slides show the photos of the wound healing progress. You can see the wound is getting smaller and smaller with clean and vascularized base. Hyperbaric oxygen therapy stopped at day 64, and the wound healed itself slowly by wound dressing eventually. This is a day 70 wound, and day 85 is nearly healed already. Okay, so this is the case of the diabetic foot ulcer treating with the hyperbaric oxygen therapy, and then I would like to discuss with the following topics. Three problems are always contributing to the development of a chronic diabetic foot ulcer. They are deformity, deep infection, and ischemia hypoxia. This troublesome triad, together with the neuropathy, often delays the patient seeking care for his condition. Shear stresses tangential to the skin surface in conjunction with deformities and bone prominence are prone to ulcer formation. Oxygen is needed in many cellular processes, from collagen deposition to antimicrobial activities. Oxygen sensitive processes, including fibroblasts, replication of collagen deposition, and angiogenesis are all essential to wound healing. And here comes the 5 important strategies in management of diabetic foot ulcer. Firstly, it is important to correct the deformities by osteotomy, ostectomy, or tenotomy. For dead tissues, proper removal is needed. Secondly, the wound should be protected and stabilized by well-packed soft dressings, spleens, removables, walkers, or fixations. This provides the best possible conditions for the wound to heal. Thirdly, optimal medical management is needed in terms of good diabetic control. Cardiac, renal, and nutritional status are also important for wound healing. Fourthly, it is important to select an optimal wound dressing agent. There are thousands of dressing agents, and it depends on the stage of the ulcer. And lastly, it comes to these sections, and we talk about the oxygen rationale to treat the wound by the hyperbaric oxygen therapy. And wound healing happens in different phases, and it includes the hemostasis phase, inflammatory phase, proliferation phase, and the remodeling phase. Oxygen is needed in all the phases for smooth wound healing. An increase in oxygen diffusion gradient enhance diffusion of oxygen to ischemic tissue beds. It provides sufficient oxygen for the wound. Oxygen diffusion at the tissue level varies in direct linear relationship to the increased partial pressure of oxygen. And the effect of hyperbaric oxygen to the wound includes, it stimulates the angiogenesis with increased fibroblast proliferation, collagen formation, and blood vessel growth. And it also stimulates collagen synthesis. It also enhances fibroblast proliferation. And finally, it enhances regeneration. There are evidence show that single hyperbaric oxygen therapy increase expression of the epidermal growth factors receptors, and also increase the player-derived growth factors receptors. Okay, there are many case reports and articles on hyperbaric oxygen therapy treating chronic wound from 1979. And there is a Cochrane review in 2015 by Peter Grain and Michael Bennett. It concludes that hyperbaric oxygen therapy significantly improves ulcers in short term, but not in long term. This is the author's conclusion because they think that in long term, the wound, there are many confounding factors affecting the ulcers. So in long term, if the patient do not have a good diabetic control, actually the ulcer will recur again. But in short term, it's obviously that the ulcers healed much quicker with hyperbaric oxygen therapy. So our recommendation for diabetic foot ulcers treating with hyperbaric oxygen therapy are the hyperbaric oxygen therapy is not used for patients with Wagner grade 2 or lower. Infection dressing and vascular status should be optimized. Hyperbaric oxygen therapy should be used as adjunctive therapy for patients with Wagner grade 3 or higher, which show no significant improvement after 30 days of wound treatment. Hyperbaric oxygen therapy can reduce major amputations from 33% to 9%. And it can significantly reduce the wound size and with higher healing rates in 1 year. The next topic, I would like to introduce the TCOM, which is the transcutaneous oximetry to all of you. TCOM measures the tissue oxygen level or tissue oxygen tension in millimeter mercury. It approximates arterial capillary partial pressure of oxygen. The normal values range from 40 to 90 millimeter mercury depending on body area measures. It can be used for screening for vessel disease, identifying healing potential, and selection of amputation level. Selection of hyperbaric suitable patients and monitoring of ventilating hyperbaric patients can also use TCOM. It is a good predictor for healing failure as hypoxic tissues does not spontaneously heal, but whether a wound can be healed successfully depends on also many other confounding factors, such as infection and nutrition. A pre-treatment TCOM is important because if the wound bed TCOM value shows hypoxic or critically hypoxia, which means the values is less than 20 millimeter mercury, it indicates that the hypoxia is one of the reasons of chronic wound condition. Oxygen challenge test, in which we have done in our case, can show the potential of healing after using hyperbaric oxygen therapy. If the values is greater than 100 millimeter mercury, as in our case, because it indicates that in hyperbaric oxygen therapy, the oxygen can diffuse well into the wound, although there is some vascular problem. Therefore, this TCOM is very useful to aid in the developing a plan of care for the patients. So this is a picture of a TCOM electrodes. It actually heat up the skin and cause the oxygen from the skin diffuse out to the electrode above the skin, and it can detect the partial pressure of the oxygen, the values. And usually the TCOM electrodes are placed around the wound so that we can know that the peri-wound oxygen partial pressure. And as I've said, these are the values of the TCOM we are using for the reference. Okay, so this is a take-home message. Thank you very much for all of your attention and your patience in learning this non-surgical technique in aiding wound healing. And lastly, the take-home message of today is always consider HPOT for diabetic foot ulcer and also try TCOM if it is available. And this is my honor as a Hong Kong hyperbaric doctor to present my case report internationally to all the surgeons here. I welcome any questions from you, as it is my vision to promote hyperbaric oxygen therapy to all over the world. And this is the end of my presentation. Thank you very much.
Thank you very much, Dr. Jeffrey. It was a wonderful presentation. And I would like to ask any of the other participants if they have any questions to kindly ask Dr. Jeffrey. Do we have any questions? Either to Dr.
Hi,
Jeffrey.
Oh.
Yeah. Thanks for your presentation, and it's a very interesting topic. And I didn't understand any clinical trials for your device, because for the diabetic ulcers we often use VSD, like a vacuum suction device to deal with the wound. Is that is that other measures play a part in healing of the diabetic ulcer?
Oh, yes, thank you for your question. Actually, in our orthopedics units, they also use a lot of the vacuum device for diabetic foot ulcer, especially if there's a lot of recurrent infection or discharges from the wound. But usually, even after they use the vacuum healing, if the wound is still cannot be healed within 30 days, then they will consider hyperbaric oxygen therapy. Because if the wound is really hypoxic wound, then even you use the vacuum dressing, it may not be able to increase the oxygenation of the wound. Therefore, we will try to assess the wound by the TCOM and also the hyperbaric oxygen challenge to see if our treatment can increase the oxygenation of the wound. If we find that it can increase the oxygenation, then we will try a course of hyperbaric oxygen therapy. And from the studies and our experience, usually a course of around 30 to 40 sessions of hyperbaric oxygen therapy can increase the wound healing in a much quicker way. And all the size and the base will become well vascularized, and even the infection rate will much decrease because of well oxygenated wound. So our experience is very good for hyperbaric oxygen therapy for the diabetic foot ulcer.
Thanks, very good point.